Good morning, everybody, to this breakfast symposium, but it can be good afternoon or even good night for you because it's a World Congress. Today, we will talk about new advances in nutritional management of pediatric Crohn's disease. We thank the Nestle Nutrition Institute for supporting this very interesting meeting. Please let me introduce myself. I'm Paolo Lionetti from the University of Florence Mayer Children's Hospital. Then I am very happy and pleased to introduce two friends, two experts in the field of dietary management of pediatrics Crohn's disease. Both are really excellent speakers. You will listen first to Professor Frank Ruemmele from University of Paris, Necker Hospital. He will give an overview of nutritional therapy for pediatric Crohn's disease in the era of biologics. And then you will listen to a talk of Professor Arie Levine from Tel Aviv, Israel. He is the inventor of Crohn's disease exclusion diet, CDD, who will give a talk on dietary strategy for the treatment of Crohn's disease in 2021 and beyond. During each presentation, you can start to ask your questions. There is a Q&A box. We invite you to do so to make this symposium fully interactive. So Frank, please, you can start your talk.
Good morning, everybody. It's my pleasure to discuss with you this morning the nutritional therapy of Crohn's disease, the place of nutrition in the algorithm of therapy. So welcome, everybody, dear colleagues, dear friends. I would like to thank the Nestle Nutrition Institute for bringing up the symposium. It's quite early in the morning, but that's a nice time to discuss together. My disclosure. So I'd like to start the discussion this morning in my presentation with a slide I guess you know very well, which nicely illustrates the evolution of the disease, of Crohn's disease, with the inflammatory burden. You see here at diagnosis, the increase of inflammation, which leads to the clinical symptoms. And with time, if inflammation is going on, there is the risk of damage of the bowel. And you will see with time appearing more and more inflammatory lesions, which will lead, if the disease is not controlled, to potential strictures and fistula formation with abscesses. So the idea of therapy is to intervene very early in the disease onset to block this process, to control inflammation, and with the aim to avoid the development of strictures or other complications. And we know there is potentially a window of opportunity, which is early in the disease onset, to control this inflammatory process, to protect the patient from bowel damage, to obtain what I show here on this slide, potential optimal situation without any inflammation over time, and more important even, the protection from bowel damage and disability. Is this aim realistic? Is this possible? I think the answer is yes for the majority of patients, and the answer is yes because we have improved therapy. We have now drugs that allow to control the disease evolution more potently and more efficiently. And the introduction, as you know, of the biologics, the first biologic is anti-TNF medication in 1999 or 2000, really changed the clinical evolution of the disease for our patients. I want to highlight and summarize the evolution and the improved care of our patients with a study that is based on a population-based cohort study in adult Crohn's disease in the Netherlands, based on 1,162 patients. And the authors separated their patients into three different cohorts. One in the early 90s until 1998, before the introduction of anti-TNF biologics. The second, 1999 till 2005, the very beginning of using these drugs, and after 2006 to 2011. And you clearly see on this slide, which summarizes this big study, that there is a marked advantage of the improved care for the patients by reducing the hospitalizations from 66 to 44% within 5 years of disease onset, And even more important, the surgical resections, the need for surgical resections within the first 5 years was reduced from initially 43% to 17%. So yes, there is a market advantage for the patient care with new treatment algorithms. And this led us to place anti-TNF drugs in the treatment of pediatric Crohn's disease in the center really of the treatment algorithm. Here I show the new algorithm of the revised CD guidelines, eco-aspirin guidelines that were published early 2020. And you see a new patient with Crohn's disease who has potential risk factors for potentially severe disease evolution will or is a candidate for early anti-TNF medication. We have currently a clinical trial running that is called Reduce Risk with an international consortium of PIBD-NET to verify and confirm that there is an advantage for patients to have early anti-TNF medication. You see on the algorithm also that perianal disease involvement is an indication for anti-TNF medication, and patients who receive induction therapy and fail or come not really into remission on induction therapy with steroids or enteral nutrition are candidates for anti-TNF medication. So really anti-TNF biologics are in the center. The question is, what is the problem? Why do we discuss this topic today? The place of nutritional therapy if anti-TNF drugs or the new biologics solve the problem for the patient, meaning we obtain the optimal control, there are no flares and everything is fine. As you know, it's not really 100% perfect. The first issue is that there are patients with a primary non-response to these drugs. Luckily, in the pediatric field, pediatric Crohn's disease patients respond better than adult diseases. But still there is a certain percentage, up to 10-15% of patients who do not respond. This is one, but even more important, the secondary loss of response. Patients who come into remission and respond to these biologics will lose with time response, probably many of them due to immunogenicity. And here's some examples. You know that within 2 years of disease onset, there's approximately 1/3 of loss of response in our patients. These are a little bit older studies. Since then, we do perform drug monitoring and optimize treatment. So the loss of response rate is now a little bit lower, but still with time, patients do not respond or continue to respond to this medication, requiring other treatment algorithms. And third, perhaps even the most important issue is that there is a potential risk of drug-induced toxicity or complications related to the drug. For anti-TNF drugs, we know infections and skin manifestations, but probably the most worrying and most important issue is cancer and lymphoma for our patients and our families, and also for us as physicians. There are several studies out with partially contradicting results, saying there is a low risk, no risk, high risk, etc. I'd like to share with you the study, which is based on 189,000 patients with IBD, based on the French National Health Insurance database, looking on, is there a risk to develop lymphoma on thiopurines, anti-TNF drugs or not? And you see in this huge study, mainly adult, but also pediatric cases included. With time, there is a slightly increased risk for patients to develop a lymphoma if they are on thiopurines in green, if they are exposed to anti-TNF drugs as monotherapy in blue, and markedly higher risk if they're exposed to both drugs as combination therapy. So indeed, there are safety signals which are important to consider and which worries markedly families and patients. So in our guidelines in 2014 and also in the revised version in 2020, we fixed the aim for our patients. The aims are to relieve symptoms, but not only to relieve, but to completely block inflammation and obtain mucosal healing. Meaning mucosal healing, if you obtain a patient with complete mucosal healing, there is a significant lower risk to have a severe disease evolution. Several studies showed this. The second point is, since we are in the pediatric field, to optimize growth, which is most often retardated in these patients, and improve bone density, have excellent quality of life or best quality of life, and, as discussed already, minimize drug toxicity. So is there a place, is there a need, is there a place for alternative treatment strategies? And if we talk about alternative treatment strategies, we talk now about nutritional therapy. As already said, biologics, anti-TNF biologics markedly improve the care for our patients, but there are still issues, loss of response with time over time, and safety issues. So indeed, many families and patients want to see other ways to treat the disease. And we know over a long period of time that there is really a spectacular effect if we use exclusive enteral nutrition as induction therapy for our patients. And the 2014 guidelines really highlight this is first-line therapy in active luminal Crohn's disease, exclusive enteral nutrition. And we still keep this clear statement and message in the 2020 revised guidelines that this is the treatment approach that we recommend in first line for our patients. Why? We know from several studies, this is one of the first reports, that we can obtain after a sufficiently long course of 2 months, complete mucosal healing is showed here from these very severe colonic ulcerations after 2 months of enteral nutrition and start of diapurins after. You have this beautifully shown picture of mucosal healing. We have clinical trials. I want to share this. It's a small trial. It's our trial we performed randomizing new patients or patients with disease flare to induction therapy with steroids or enteral nutrition in form of model IBD. And we know that there is a high efficacy of both treatment arms, even if the enteral nutrition treatment option had a higher rate of normalizing Harvard-Bradshaw index for as measure for remission. But more important, we see a significant difference of mucosal healing on induction therapy with Modulant compared to steroids, which echoes previous studies. This is the oldest study from our Italian colleagues looking on enteral nutrition versus steroids, exclusive enteral nutrition in white, steroids in black. They observe mucosal healing, and even on top of this mucosal healing, they look on histological scores, and they see in the ileum and in the colon a marked reduction of inflammation. This is the histological score in patients on exclusive enteral nutrition, whereas steroid medication barely reduced this inflammation score. So we know exclusive enteral therapy as induction therapy is as efficacious as steroids, old meta-analysis, but still true. We have mucosal healing, but since this is an exclusive diet, meaning only milk product and nothing to eat, the question is, why do our patients accept this induction strategy? It's not so easy to follow this, and there are several elements of answer. I think the most important element is the growth retardation in the patients and the potential of catch-up growth under nutritional therapy. You see one of my patients who received in red a steroid course the first diagnosis in another center, which really aggravated growth retardation, and on in green a relapse treated with nutritional therapy, there's a start of catch-up growth. This is one argument to use nutritional therapy. The second argument is that there is a very fast effect on introduction of exclusive enteral nutrition. This is a British study a couple of years back. You see a marked drop within a couple of days of inflammatory parameters, which highlight that clinical symptoms disappear or improve within a couple of days. So a clear benefit for the patients, which motivate them really to stick to this treatment option. We know, this is a randomized trial of British colleagues, that maintaining normal food and just adding a supplement of nutrition is not sufficient. It is the exclusivity which makes it a strong treatment option. You see, comparing partial versus total or exclusive enteral nutrition, the PCDI score significantly drops if it's exclusive, as well as the diarrhea subscore. On partial enteral nutrition, there's just a relief. Oral route versus enteral route. In the beginning, it was only via nasogastric tube feeding. We showed this a couple of years back, comparing patients on oral model and IBD intake versus nasogastric tube intake. There is no difference over the 8-week period in efficacy. It's a little bit faster if it's oral, if you look on the 4 weeks result, but in the end, it's the same. And the oral intake is markedly better tolerated by the patients than nasogastric tube feeding. Which type of diet? Old meta-analysis, but still holds true. There is no difference if you use elemental diet or polymeric diet. The big difference is if you give it orally, the taste and the acceptability of polymeric is significantly higher compared to elemental diet, which is difficult to take on an exclusive basis. What is the principle of exclusive enteral nutrition? Orally taken or by nasogastric tube feeding, no difference. It is no normal food, meaning you exclude all food and it's just based on the milk product you choose for 6 to 8 weeks, and it is working for all types of presentations of luminal disease independent of the location. So colonic disease, ileocolonic disease, small bowel involvement, but not for perianal disease. We now have, and I think this is will be discussed by Arie Levine in the following talk, a different approach which potentially helps us to make this nutritional therapy even easier for our patient with a very restricted diet, avoiding to have only milk-based alimentation, but also some food ingredients. Arie will develop this and we discuss this in the end. What is the effect? Several hypotheses. One clear effect is, this is a cartoon of the intestinal mucosa with the immune system underlying. It's in the ileum, and you see here in the lumen the different antigens, and mainly the microbiota, which are disturbed, the dysbiosis in IBD, and the immune compartment, all the different actors that create inflammation. The idea is that the intraluminal content, mainly the dysbiosis, but potentially also food ingredients, trigger an inflammatory pathway. And if we can change this dysbiosis or eliminate some nutritional elements that create inflammation, we will reduce this impact on the immune system and reduce the inflammatory load. So potentially treatment on top of the inflammatory cascade. I guess Arie will develop this in this talk and we discuss in the end. And we know, data from our lab, but others showed this also over the last years, that there is a clear effect on the dysbiosis in these patients. Shown here before therapy, in our randomized trial, you see on steroid medication, the microbial profile shifts in a completely different manner compared to exclusive enteral nutrition here with Madeline. And if you look more in details, you will see clear differences on and post therapy with lower firmicutes, more acinetobacteria or bacteroides. So now I want to look a little bit into the future and translate these findings we have today for what can we expect with nutritional therapy for our patients, what might be the next steps. And our idea was, and this is a design of a clinical trial to answer this question, is there a place for nutritional therapy to maintain remission for patients who respond to exclusive enteral nutrition, then to maintain them over time having an approach as maintenance therapy for nutrition? The design of this study called CD Hope, which was performed at the French Pediatrics, is patients who respond to exclusive enteral nutrition over 6 weeks will be randomized to return back to normal diet, and they just keep a daily supplement of 25% of their energy intake with modern IBD, versus patients who will have every 6 weeks, a 2 weeks cycle of exclusive enteral nutrition. And we look at the 12-month endpoint, the rate of remission or the rate of relapse. Is there a difference? And I can tell you that for the very first time, we will present the results of this study. It will be this afternoon, my colleague, Dr. Bénédicte Pigneur, in the plenary session, highest scoring abstracts at 4:05. She will present the data, but I guess you're a little bit curious, and I will share one first result with you and invite you to see the whole story this afternoon, which is the remission rate. There is a clear, significant result of this study showing that over 12 months, the group who receives the cyclic exclusive enteral nutrition 2 weeks every 6 weeks has a higher remission rate, lower relapse rate compared to the group who return to normal food with just a supplement. So very exciting results. So please come this afternoon to discuss and see the study in details. With this, I'd like to summarize and conclude that we know that exclusive enteral nutrition is highly effective. It has an excellent safety profile. It is well accepted by our patients, better if it's orally taken. And we know with the potential induced mucosal healing, there's a real top-down approach possible for exclusive enteral nutrition. And Arie will introduce the concept of exclusion diets with the same potential. And here I open for the first time that nutritional therapy might be an option for long-term therapy for our patients, meaning there is an alternative to long-term medication in form of nutritional therapies for nutritional responders. With that, I'd like to thank you very much, and we'll take the questions and have a discussion in the end of this symposium. So thanks a lot.
Hi, everybody. Well, I miss seeing all of you in person, and today I have the pleasure to talk to you today about dietary strategies for the treatment of Crohn's disease in 2021 and maybe beyond. I miss all of my friends whom I cannot see, and I'm hoping we'll get together soon. These are my disclosures, and I will not be promoting any commercial product in this talk. So what is a strategy? A strategy is a general plan to achieve one or more long-term goals under conditions of uncertainty. And the emphasis here is on goals. And if we take a critical look at the way we work in Crohn's disease, we only really have one strategy. I'm not talking about all sorts of tactical decisions about which drug. The strategy that we can employ in a mild to moderate patient, not the surgical patients, for instance, is either accelerated step up or top down. That is the only discussion that we really have. Since a strategy is dependent on goals, let's review the goals of therapy for Crohn's disease briefly. They are, of course, to, if a patient is active, to induce clinical remission, to decrease inflammation, and to maintain that remission and maintain growth in children. In a longer time span, we would like to achieve mucosal healing. We would like to prevent complications and reduce surgery. And it's not clear that any of our therapies really do that at the present time and do no harm. I would like to add that we would also like to reduce or avoid immune suppression in children and reduce or avoid serious side effects. And some of our drugs do have a potential over a prolonged period of time to cause possibly cancer as well. So Crohn's disease is clearly an environmental disease nowadays. It's on the uprise all through the world. It's a global disease. The genetics haven't changed. And in any progressive environmental disease, disease control, cure, and prevention can only be achieved if the environmental cause of the disease is addressed. How many of you have addressed that with your patients? Because our current strategies are based on remission data. Induction of remission data, maintenance of remission data, maybe even mucosal healing. But none of our discussions have to do with addressing the environmental component and how that might affect the disease. We have to recognize, and this is going to be the theme that I will try to raise in every conference in the next year or two, that we have a new phenotype of Crohn's disease. It's called the disease or dietary responsive phenotype. This is a really important phenotype that we have to recognize. Multiple studies have shown that habitual free diet can trigger Crohn's disease. And we've seen this in numerous exclusive enteral nutrition studies and even in the CDD study published in Gastroenterology, where there was a rise in calprotectin and loss response after reintroduction of food. Kostas Gerasimides' group has also shown very nicely with Richard Russell that there's a rapid rise in calprotectin despite partial enteral nutrition when you reintroduce food. But this was not seen with Crohn's disease exclusion diet maintenance phase, suggesting that reduction in exposure to certain foods is important in this disease. We just have to try to figure out which foods they are. There's some new data that has come out over the last year or two since coronavirus hit us all. And I'm going to just bring this really briefly because I think we should all be aware of them. There are 3 new studies in 2021 looking at the effect of emulsifiers, carrageenans, and gums on the microbiome. And almost all of them have shown a toxic effect on the microbiome of many of these components or a pro-inflammatory effect. And what is really interesting, and this is very relevant for our formulas that we're using, is that soy lecithin might actually be the safest emulsifier. It may not have any effect on the microbiome. In 2 studies, it did not show an effect. And in a 3rd study, it showed an effect at a higher dose. So this may be dose dependent, but that clearly is good news for us. Before we move on to how we're going to integrate diet into our strategies, I'd like to put some evidence out there, and I apologize if I'm going to bore you with a slide or slides that you've seen before. This is from the gastroenterology study, and I'm going to show you some studies that you haven't seen, published in 2019, a head-to-head trial versus CDD versus exclusive enteral nutrition. And you can see here clearly that there was a really nice clinical remission at week 6, and it was not different from that seen with exclusive enteral nutrition. And this is using the most rigorous endpoint, not the common endpoint. This is PCDI less than 10. And we can see, though, at week 12, there was already a disparity or divergence between the 2 groups. It was almost double the amount of sustained remission in the CDD arm, which is now in the maintenance phase, compared to the EN group, which is on partial enteral nutrition, but with reintroduction of regular food. And this is also seen in the calprotectin data, such that there was 76% reduction in calprotectin by week 12. And this is a continuous decline compared to a similar decline through week 6, but then rebound in calprotectin in the exclusive enteral nutrition arm, such that there was a huge difference in decline in calprotectin by week 12 using the CDD strategy. Why is this important? Aside from validating CDD, it means that food is driving inflammation. If food is driving inflammation, we have to integrate this into our treatment strategy. This is also shown in microbiome data. I'm not going to bore you with this. I'm just going to say there's some exciting new data that are going to be presented this year by us and by Johan, showing more about the role of proteobacteria in dietary responsive disease. But what was seen in this study, and on the upper panel, you have the Crohn's disease exclusion diet, and in the bottom panel, you have exclusive enteral nutrition. And on the left-hand side, week 0 to 6, that there was a decrease in proteobacteria with both therapies that was very similar in magnitude and in the genera. And there was a similar expanse of firmicutes, which was even stronger with exclusive enteral nutrition during the first 6 weeks. But this was completely lost once food was reintroduced. There's no decrease in proteobacteria. Now these patients are back at their baseline dysbiosis, whereas there's a sustained decrease in proteobacteria, and the p-value is even higher now compared to baseline because this is sustained. We also saw that only CDD with partial enteral nutrition improved intestinal permeability, and there was no improvement in intestinal permeability at week 3. So this is while they're on exclusive enteral nutrition, there's no improvement in intestinal permeability. So it's not addressed by exclusive enteral nutrition. So I'm sure that most of you are aware that Crohn's disease exclusion diet is a pathogenesis-based diet, and it's a modular diet that's geared for long-term use. There's an induction phase shown here in blue, which is phase 1 and phase 2 over the first 12 weeks, which was shown in the gastroenterology study. But then there's a maintenance phase, which we usually recommend for 9 months, and I'm going to show you some data about that. And then once patients have completed that first year and they're doing well, and if they cannot sustain it, we just move to or adapt that diet to a lifestyle that's personalized for each patient. And it's not something that I can bring about on the slide or show you on the slide. What's really important, and this is another paper that came out from the CDD study, is showing that the response to both CDD and exclusive enteral nutrition are very rapid. An 85% or 82% response at week 3. And most of the patients who will achieve remission actually do so in the first 3 weeks. And this is accompanied by a similar decline with both groups in CRP. So this is a rapid inflammatory response as well. And we can use this rapid inflammatory response to identify dietary responsive patients. We don't have a biomarker in the blood or the stool, but an empiric trial with either exclusive enteral nutrition or Crohn's disease exclusion diet for 6 weeks is our biomarker for dietary responsive disease. What you haven't seen to date yet are the adult data, which are now submitted. And this is a randomized pilot trial comparing Crohn's disease exclusion diet with partial enteral nutrition to Crohn's disease exclusion diet without partial enteral nutrition over 24 weeks. I'm going to show you the pooled data because it doesn't really make a difference right now for this talk. And these are the pooled data in adults. So most of these adults are at diagnosis, just like in the pediatric trials. And what you can see here very nicely is that there's a similar magnitude of response. 62.5% are in remission at week 6 with dietary monotherapy, no drugs. But look over here. At week 24, 52% are in sustained remission with dietary monotherapy, no drugs. And 35%, had intention to treat endoscopic remission at week 24, and was higher for patients who remained in the trial and were compliant. So just for every patient enrolled in the trial, more than a third of them had endoscopic remission at 24 weeks in a follow-up colonoscopy. So Crohn's disease exclusion diet clearly maintains remission very well and induces or sustains mucosal healing. And I think that in this case, this is the only dietary therapy and maybe one of the few medical therapies that meets all the goals of Crohn's disease. It induces clinical remission, causes a decrease in inflammation, maintains remission, achieves mucosal healing, does no harm, and clearly avoids immune suppression. So having shown you those data, let's talk more about treatment strategies. And until now, and you might disagree with me, but I think there are 4 different parameters or variables that will decide what a patient is going to get. These are the 4 phenotypes that drive treatment decisions. Disease severity. Does the patient have a complicated disease phenotype, or such as stricturine or perianal fistula? Does the patient have extraintestinal disease, such as arthritis? And who is the physician? That's maybe the most important phenotype. Does the patient, as a physician, who's a top-down person or an accelerated step-up individual? But I'd like to change that paradigm. And I'd like to suggest that there's a 4th phenotype that's not physician-dependent, which is dietary responsive disease. And we should be finding out who these patients are, who has dietary responsive disease when we first meet the patient, preferably at diagnosis, because it could change our treatment strategy. And it has changed my treatment strategies. I'm going to show you what we do right now in my center. So let's take an uncomplicated mild to moderate disease patient at diagnosis, which is, according to guidelines, a person who's supposed to start exclusive enteral nutrition. And for this strategy, you could use either CDD stage 1 or exclusive enteral nutrition. Are they willing to try the diet? They start CDD with partial enteral nutrition, and you find out if they've had a really good response. Do they have clinical remission and a really nice drop in inflammation? So they're dietary responsive. This opens up 3 different new strategies that we didn't have before. And the first, which is exciting for patients, which I don't think the majority of our patients are going to use it, but it's very exciting when it does, is CDD monotherapy, just like in the adult trial. And we have many patients nowadays who have never received any drugs, and they start out with CDD, and at week 6 or 12, we see that they're doing really well, and they've had a decrease in inflammation, and they continue on maintenance, and they're drug-free. The more common strategy that we use is the middle strategy, which we'd like to combine diet and drug as a combination therapy for the first year. That addresses the environmental component because we're removing factors that we assume will be driving inflammation, and we're addressing the inflammation very nicely with drugs that we know that work. However, if after a year, patients are in complete sustained remission and have mucosal healing, we can offer drug de-escalation if they're willing to continue with diet alone. And this is a reduced drug strategy. And of course, we will have patients who will require medical therapy because they don't respond, or who are not motivated to continue with dietary therapy, and that's fine. We have to accept that dietary therapy is not for everybody. And in those patients, if we know that they're dietary responsive, we can use CDD as a rescue therapy if they fail or lose response to biologics. And we're using that. I'm going to show you some how we do that. So let's break this down. We have our mild to moderate uncomplicated patient, and they want to start monotherapy. They don't want to receive drugs. Who are the population that we could offer this to? Again, patients who are uncomplicated, no joint involvement, and are motivated. The advantage, of course, is no drugs And the disadvantage, and it is a disadvantage, is dietary dependency. And we usually make this decision more at week 12 if it's up to me, but sometimes at week 6. And if they're dietary responsive, and once they're experienced in the stage 2 diet, which is much more lenient, then they'll know what it's like to be on a maintenance diet more. And the motivated patient knows that the hardest part of the diet is behind them. In a worst case scenario, it's not the worst case scenario, but in a scenario where the patient doesn't do well 6, 9, 12 months later, and if they have a flare or an elevation of calprotectin, we just regress to the first stage of the diet for 6 weeks and then continue the maintenance diet. And this is successful in most cases. And I know of other centers who are using CDD who have the same observation. We like to say once dietary responsive, always dietary responsive. It's not 100%, but it's very common. But if inflammation is not controlled, then we just move on to drugs. What about a drug and diet strategy? Who do we use that for? For non-severe Crohn's disease patients. This would be using combo therapy, addressing both microbiome and inflammation. This allows us to offer de-escalation of therapy, and this is actually something patients will buy into who don't want drugs. You say, take drugs for the first year, and if you're doing really well, we can have a discussion about stopping drugs in a year if you're willing to continue diet. And the disadvantage, of course, is using a drug for the patient. We usually will offer methotrexate if the patient is non-severe because we can discard this really easily, but I don't mind discontinuing the first anti-TNF because we have others at the present time. And we can decide about de-escalation after 1 year if there's complete mucosal healing, the patient is willing to perform the maintenance diet, and in the worst case scenario, if that strategy fails, we move on to anti-TNF. We wouldn't have reached this point if the patient had been doing well because we're monitoring the patient throughout the year. And lastly, we can use diet as a rescue therapy. We've published about this in the past. We saw 62% of patients who failed anti-TNF respond to dietary therapy, rescue therapy. And I'm sure it's about 50% in our population right now, maybe not 62%. Also has to do with duration of disease. And we can always use this as a backup therapy. Until now, we talked about uncomplicated mild to moderate disease. But let's switch gear and talk about complicated mild to moderate disease. Because even in these patients, I know I'm going to want to start an anti-TNF. There's a perianal fistula. There's the beginning of stricturing disease. I would still start those patients on Crohn's disease exclusion diet with partial enteral nutrition as a bridge to medical therapy. If they're new onset patient, I prefer to use the first stage and induce remission and see how they do. And then we can decide about combination of drug and diet or medical therapy alone. But if a patient is clearly going to go on to an anti-TNF, let's say a patient has a perianal fistula, you know that you're going to give that drug. You know that the patient knows that they're going to get that drug. Then there's another strategy that's open that we can use. That's a dietary strategy. And that's not to use first stage CDD or exclusive enteral nutrition. It's to put them on medical therapy and put them in a reduction in dietary exposure strategy. And for instance, we can use CDD phase 3, which has free meals, which reduces exposure, but it's not really complete. It's not enough to induce remission, but it reduces exposure. And the proof of that is, of course, that it works for patients who've been to the first 2 stages. So we do this as well. So if a patient is not motivated to use dietary therapy, say, let's personalize it for you. Try to avoid these foods, try this diet, and we start from phase 3. In conclusion, I believe that CDD is effective for remission in children and adults. It can induce and maintain remission as monotherapy in greater 50% of patients in adult patients, which are actually a more difficult category than pediatric patients. It's associated with a decline in calprotectin, CRP, and mucosal healing at 6 months. We have a biomarker, and that biomarker is a clinical course to identify dietary responsive disease using either exclusive enteral nutrition or CDD with PEN, which I think is much easier. And the ideal time to detect this phenotype is at diagnosis before we've started any drug, because if you use it in combination with the drug, you won't know what actually induced remission. We can use CDD phase 1 for identification of dietary responsive disease and induction of remission. And we can use the second or third phase as a reduction exposure strategy for patients we know we're going to start biologics on because they have a complicated disease course. Other diets may be able to provide reduction in exposure, but need to be rigorously evaluated. And with that, I'd like to conclude. My time is up, and I'd be happy to take your questions during the question and answer session. Thank you very much.
Thank you very much. Two excellent talks, I would say. We have questions, but before that, I would like just to do some remarks about this very nice talk. Prof. Ruemmele underlined the capacity of anti-TNF-alpha therapy to reduce hospitalization and surgery after 5 years. And there is anyway the problem of risk of infection, skin problems, and then even if it is rare, especially with combo therapy, the risk of lymphoma. We are using exclusive enteral nutrition since a long time. We can say that it's effective. It can induce mucosal healing, and its role is confirmed even in the last Porto SPNCT guideline revision. I would say there is always a problem of acceptance of the monotony of a liquid diet, and then the high frequency of relapse with the exclusive enteral nutrition interruption. And Prof. Ruemmele is proposing a new strategy in a new trial after a course of 6-week course of exclusive enteral nutrition, to continue to have every 8 weeks, 2 weeks of exclusive liquid diet. Then Prof. Levine have introduced new concept in the therapeutic strategy of Crohn's disease. I would say both for adults and children, we should consider Crohn's disease as an environmental disease, and even for any progressive environmental condition, disease control, cure, and prevention can be achieved if the environmental cause of a disease is addressed. There is no point if you have a lung disease, you have to stop smoking. CDED experience suggests that the reduction of exposure to certain food is important. In my experience, it works better than exclusive enteral nutrition on the long term in maintaining remission and a low level of caprotectin. And there are new studies now underlying and confirming the negative effect of the microbiome and gut mucosa of a diet, some dietary components such as emulsifier, carrageenans, and gums that are excluded in CDED. And an important concept suggested by Prof. Levine is the selection of dietary responsive patients, a phenotype that is not dependent, for instance, on the physician attitude to prefer top-down strategy or accelerated step-up approach. And then there is also a possibility that a subgroup of patients can be maintained in sustained remission with a diet therapy alone. CDD plus partial enteral nutrition, for instance. So avoiding completely drug side effects. So maybe diet can be considered as a biomarker to select patients with a dietary responsive disease. Then we can start our Q&A session, and there are many questions. I would start with Daniela Serban. Hi, Daniela. It's night. I'm sorry we can't see you. So the question by Prof. Serban is, hi, Frank, good morning. Could you please discuss the impact of exclusive enteral nutrition on transmural healing?
Very interesting question. I think we have to answer this question with the evidence in the literature. And I have to admit, in the study I presented to you, we did not look on systematic MRI analysis in the majority of patients. We just have a subgroup of patients. I think from the physiopathology of the disease, if we obtain mucosal healing, if we see disappearance of the lesions, what was looked after in several studies now, there's a good chance also to see the reduction of the inflammation on the submucosal level, which is measured by MRI. But before we have precise MRI data on the patients, I will stay prudent by saying it looks like it's improving, but we really have to prove it in studies. I don't know, Arie, if you have measurements of MRI where you can confirm indeed it is significant in the patients. We have the trend, I know it, but do you have significant data in your studies?
So we do. First of all, we have a study that's ongoing with intestinal ultrasound, but I don't have the data from that trial yet. But we do see patients because we have our patients that we're de-escalating at 1 year, and we're doing that every month. We have a patient like that at least. And so they have to have a normal MRI and normal calprotectin, so they have transmural healing. Otherwise, we don't even offer the de-escalation. So yes, we're seeing this in clinical practice, but when does it occur is a really interesting topic. So now we're performing serial ultrasound and looking at the effect. But I have seen patients who have had improvement in ultrasound with exclusive enteral nutrition as well. So it has an effect on transmural healing. I can't say it's complete or not complete, but there's a reduction in bowel wall thickness with exclusive enteral nutrition.
I think the timing is important because it takes time to obtain mucosal healing. That's what we know. If you look after 2 or 3 weeks of nutritional therapy, either exclusive enteral nutrition or CDD or other diets, that's too early. And transmural healing, it's the same. It's not after a course of a couple of weeks. So that's the reason why the data is missing from the induction trials. But on the maintenance trials, I think we'll have this information very clear. From the patients I have in my center, which were in a CD Hope study, indeed, a mucosal healing was obtained in those who have follow-up endoscopy in, well, Benedict will present you this in the afternoon, in a large number, but the MRI data in those patients who had it, there's a clear improvement. So my guess is yes, but let's see the data.
There is another question, Bhutania Zemrani from Dr. Zemrani. Thank you for these 2 great talks. Nutrition therapy has clearly revolutionized the treatment of IBD. In your experience, how this therapy, especially CDD plus partial enteral nutrition, could change the quality of life, compliance, and satisfaction of patients? And I would like to ask, to add to this question to Arie, how did you succeed with this kind of treatment? I mean, which kind of, do you use the dietitians, and then you use some application as model life application, I mean, to deal with this therapy that is not so easy to perform?
So thank you. And I agree, it's not simple. I mean, it is a challenge. It's really a challenge that's not that difficult for a physician or the dietitian if you're organized. So you have to have a program. You have to have a recipe booklet from the first day. You have to tell patients in the first week, cook up these foods so you find the foods that you like. And really, patients have to understand that from week 7, everything changes. And once in the second phase, most patients don't complain and say, it's not that bad at all and I can do this. However, there are different people. So there are foodies, people whose pizza is the most important thing to them, or adults who, if you have to tell them they can't have wine every day, then they're in an uproar. And we have to recognize that. So dietary therapy as a maintenance therapy won't be for everybody, but in children, it's quite successful. And in children who succeeded during the first 3 stages, in other words, phase 1, phase 2, and go on to phase 3 and are doing well, during the first year, we have 60% of patients still on the diet with high compliance. So that's very high. But over time, it will deteriorate. And therefore, you need the more motivated patients if it's going to be monotherapy. The most important thing is really to provide all the support up front. If you just hand out a handout to a patient, say, take this diet, they're going to find it very difficult. It requires more support in a way than exclusive enteral nutrition. But it's really important that you get organized. It's not that difficult. And as you said, there's a Module Life program, and dietitians can be trained with the recipes. So I think it's just very individualized and personalized.
I completely agree. Yes, we do the same. There is a question by Mingwei Lai. I think it's for Frank. Does cyclic exclusive enteral nutrition in maintenance together with immunosuppressant therapy, or even Arie with CDD, do you do combo therapy with nutrition and an immunosuppressant or not?
I think the answer is very clear. You can combine, and Arie developed this very nicely in his presentation. The clinical trial CD Hope was without drug therapy. These were patients who had relapse, or the most of them were at the diagnosis with active disease, who did respond to nutritional therapy, exclusive enteral nutrition, as Arie developed. These are nutrition or dietary responders. This is the typical phenotype, and these are the candidates. You will not do maintenance nutritional therapy in a patient who is failing to respond in the very beginning, because there's no sense to make it on the long term. So the question to add drugs, I think you can maintain drug therapy and on top have a nutritional approach with the aim to de-escalate. I already developed this very nicely in the presentation, just you heard. Or you can add on top of drug therapy, the nutritional therapy, by maintaining both. So you can really use this combination, and I think you consider nutritional therapy as another way of drug therapy without using drugs. It's just the nutritional part. And the answer is yes, you can combine without any problems.
May I make a comment?
Perhaps you want to develop, Arie, yes.
I don't want to develop. First of all, I want to applaud you for performing your study. And now we have two different maintenance trials using two different strategies, both changing only food without drugs, showing that you can maintain remission in patients over time. And I think this is really important because this demonstrates the role of food in causing disease in a majority of our patients. And right now it's not part of our strategy. So I think that there might be many different strategies that we could employ down the line, but we have to employ at least one strategy that's rational, that includes this in dietary responsive patients. And I'm very grateful to you for performing that study, Frank.
Thank you. That's very kind. I think what we clearly learn from these studies and what we see is that returning to normal food makes the patient unstable very, very quickly.
Yes.
What we saw in the other arm, you have a nutritional response, like we know from the beginning with exclusive enteral nutrition, and then the patient returns back to normal food. The inflammation is coming back very quickly. And that's what we saw in the other arm in the study, very high relapse rate.
Yes, it's the food is driving inflammation. Yes, there is a rebound you see immediately with calprotectin. So there is another question. Maria Estrella Ronquillo Nolasco. Are nutritional therapy dietary strategy beneficial for Crohn's disease with perianal disease, fistulizing and non-fistulizing? Well, I could answer to these questions. I mean, they are certainly beneficial, but if you have a complex perianal disease, you should do surgery first. And then the guideline suggests to use directly anti-TNF therapy. I would say, but this is my opinion, if you do a good surgery, then any kind of treatment that is efficacious, you can use. But anyway, as an add-on therapy in this condition, I think that nutritional therapy can be beneficial. I don't know if you agree with that, Frank and Arie.
I would say a standalone therapy, just as you said, Paolo.
Not alone.
Therapy is not sufficient. It will support the patient. Most often there's luminal disease, so you will have to decrease the inflammation on the luminal disease. Many of these patients have both retardation and denutrition, so that's another way very important to support the patient. But you need precise therapy for the perianal lesions, which is drainage, perhaps antibiotics, and we in our center usually use for all patients with complex therapy anti-TNF medication, because you will obtain closure of the fistula very quickly, and it's a pity to wait too long. So nutritional therapy is an adjunct therapy in these patients, but not the standalone therapy.
Yes, that's right. Then Nicolette Poe, can you tell something more about the diet itself? What type of foods are eaten by the patients? I mean, this is difficult to answer to these questions. It's too long, but just can you summarize briefly the CDD, Arie?
Yes.
What do you exclude? What do you exclude?
So in phase one, if I had to encapsulate the phase one, because of course it changes every 6 weeks, and that's one of the advantages of this diet, is that it's a high protein, low fat, low heme, no gluten diet with no additives. And so what we prioritize is use of chicken breast, which is a lean cut of meat, which has low sulfated amino acids, so it's less likely to trigger colonic bacteria that we think might play a role. We allow eggs, we provide resistant starch, and of course we provide partial nutrition for balance, and we're excluding animal fat and saturated fat. So we reduce all other forms of chicken or other meats and all processed foods. We exclude dairy products completely during the first 12 weeks because they are a source of saturated fatty acids and emulsifiers. And we exclude wheat because that induces intestinal permeability. And actually, CDD is the first and only dietary therapy, and maybe the only therapy so far that's shown to improve intestinal permeability so rapidly. And I attribute that to also the avoidance of gliadin during the first 12 weeks. So that's basically what it is. So we're giving fruits, vegetables, chicken, eggs, rice, potatoes, and of course the partial enteral nutrition during the first 6 weeks. In the second 6 weeks, all the fruits and vegetables come back. If you don't have a stricture, you don't have to peel the fruits and vegetables anymore. And we increase the fiber. We start introducing legumes, and we introduce a slice of bread, and then we reduce the amount of partial enteral nutrition so it'll be more palatable. And at the third stage, there's free meals on the weekends, and there's all parts of chicken, and there's beef once a week. So there's gradual introduction in that fashion, and they can go to restaurants in the third stage.
Yeah. It's an education to good diet anyway. This
it's very hard to answer in 1 minute.
Yeah. But you manage. Okay. This is, I think, is important. Solid, Alan. What is the role of a dietitian in your clinic? I mean, it's very important, and it's less work for us. Do you agree with that, Arie and Frank?
I'll let Frank answer first.
Do you use the dietitian?
Okay, he's not answering. Yes, I employ several dietitians. So I have 3 IBD dietitians. And all our patients, I will even share that we have an ulcerative colitis diet, and now we're using diet in ulcerative colitis as well, but we haven't published the data yet. We're going to publish it this year. And so all our patients are seeing dietitians and getting some sort of dietary therapy if they agree to it. And it really, without it, it would be impossible to manage all these patients with dietary therapy. There's also a support system. It's not just meeting them for the first time. There are going to be questions. So we have a hotline and have a dedicated email so patients can send in questions. So we have a whole program. And of course, we ask them to, when I, for instance, introduce the diet, I'll share which recipes I like the best, because I did the diet for 8 days when I was developing it. And I have a good feel for the diet. And if they cook up all the recipes from the very beginning, it makes it easier. But it's really hard to do this without a dietitian. And I think that dietitians are therapists, just like surgeons, like doctors, and just as important as an IBD nurse. It's part of the multidisciplinary team.
Yes, I completely agree with you. There is maybe time for some more questions, just a few minutes. Dr. Zemrani, are there any markers of indicator that can help predict dietary response in patients based, for example, on microbiota, butyrate, genetic profile? I don't think so, but just to see what's going on in the first 2 weeks, if there is a dietary response, you can have a very quick response. And then you can follow it even with the clinical activity and calprotectin. I don't know what do you think?
I can answer. So I don't know the answer to this, but I can't predict who is. But there might. Johan van Limbergen thinks that he might predict who won't. So it's a different way of looking at it, and it could be that people who have a very, very high proteobacteria burden are less likely to respond just with diet. Because the burden is so high. And we have really good data showing what happens, which I think it might be shared during this meeting. And so I don't want to steal Johan's thunder on this. But there's Escherichia is one of the genera it takes more time to reduce it. So you might not see as rapid a response when there's a really high relative abundance.
Okay. Very quick question. Have you found any role of keto diet? I have no experience in treatment of IBD. No. I think there is no point. Okay. Then this is maybe one more question. Prof. Dr. Vasquez. To Dr. Levine, when there is affected colon A1, L3, is perhaps better added mesalazine besides diet therapy? Thank you and congratulations.
Thank you. I don't need to. So, first of all, colonic disease responds to dietary therapy. I do believe that it responds less well, but it still responds in a large number of patients. I don't use mesalazine with my patients, but for severe colonic disease, I do add antibiotics. I use azithromycin. And if a patient has like severe proctitis, I might use a suppository, but I don't give routine mesalazine in Crohn's disease at all.
Okay, me too. Okay, we have to conclude this symposium. We are perfectly in time. Thank you for both
Thank
speakers,
you,
and bye-bye to everybody. Hope to see you in person next time. Bye-bye. And thank you, Nestle, for organizing and supporting this.